Welcome to today's webinar. This is a webinar format, so just some quick housekeeping items. In this format, you will not be able to unmute yourself and you will not be able to turn your camera on. However, you will be able to ask any questions of our presenters today by using the Q&A icon, which should be located on your Zoom toolbar. So you can use that at any point, and time allowing, we will get to questions. And with that, I'd like to start us off by turning it over to Trish.
Great, thank you everybody. This is Trish Riley with the National Academy for State Health Policy. We are very pleased to have you here for this important and timely webinar, State Strategies to Build Vaccine Confidence. We meet at an interesting time as governors particularly are thinking of new strategies, everything from million-dollar lotteries to driving in a pace car to getting a new car to try to induce people to vaccinate. So we'll hear some more strategies as we go forward today. I first want to very much thank AM Trace, an important company in this space, for sponsoring this webinar, and note that the content of the webinar is NASHB's alone, but we're very grateful for that support. So without further ado, we're going to walk through a set of presentations. Please enter your Q&A in the Q&A function. We'll follow up with as many as we can, but ask the questions as you think of them, just type them in. And we're going to time each speaker so that we'll have plenty of time for questions and answers. I'm very pleased. First, I want to thank two from NASHB, Jill Rosenthal and Ariella Levinson, who've been doing so much work in this space and have been instrumental in getting this webinar together. So thank you to all. Let me present our speakers in the order in which they'll speak, and I won't reintroduce them again so that we can make maximum time for speaking. We'll first hear from Richard Porterone, who's the communication co-deputy at CDC, and we're very grateful that he made time in a busy schedule, as did all our speakers. Next, Dr. Douglas Raymond Lyon, who's the senior health advisor at the Oregon Health Authority and has both Oregon and international experience to share with us. And Jens Dakin, who's the managing director of information operations and strategic communications at AM Trace. So Richard, Douglas, Jens will take it quickly through their presentations, which I think you'll find most engaging. And then again, we'll have plenty of time for Q&A. So add your Q&A as you hear them. For those who are interested, the slides will be available and we are recording this presentation, so it will be available following the webinar. So with no further ado, and great thanks to our speakers, let me turn to Richard.
Great, thank you. I'm Richard Porterone. I am a communication co-deputy on the vaccine task force, and my day job is in the immunization services division doing domestic immunization. So this is my day job as well as my response job. And what I'll be talking about is really providing kind of an overview of communication and our, at the core of our vaccine confidence strategy. Next slide, please. So one of the things that is incredibly important about building confidence and ultimately building vaccine demand is that confidence and demand really start with trust. We see this we see this in our regular routine immunizations, and we especially see it in a time of crisis and in a time of emergency response. And trust is personal and individual, but it is not something that is solely set on a communication campaign or a specific kind of relationship. It really is a process and something that starts with trust in the vaccines and the process behind that, trust in the providers, the individuals, and the organizations who administer the vaccines, and all of the processes and policies that lead to that vaccine getting to you. So we take this very seriously and work this into our day-to-day work, and have worked this into our overarching strategy for not only the communication efforts that we're doing, but for the entire program overall. Next slide. As when we do talk about confidence, it's important to put this into perspective. It is normal and rational to have questions about something that's new that you don't know a lot about. On our side, on the public health side, I always have to remind myself that I am seeing this, I am living this, working very long days, hearing all of the information, and I have to remember that not everyone has the time, energy, or attention span to pay anywhere near as much attention to this work as I do, and that our job as public health professionals is to be that bridge and to answer questions that will help people understand the process, understand the vaccine, and put the risk of disease and the benefits of vaccine into context. And we see that play out in our polling over the last several months, where we see people roughly moving again into sort of this rule of thirds, where we see people who've already gotten the vaccine that we can consider early adopters. We see that the group that HHS likes to call the movable middle, and that second 30%, sort of, and into the next 17% of individuals who want to get it soon or might want to wait and see. And then as we get farther down the line into that last 15 to 20% of people, that's the group that we would call hesitant. I think it's really important in the context of how we talk about all of this, that we don't inadvertently create more hesitancy than is really there. We have the vast majority of people understand the vaccine. So 60+% just right off the bat have favorable views of the vaccine. If you look at sort of, I've already gotten it or I want to get it soon. And even the people who are wait and see, many of them have confidence in the vaccine. They're just not motivated in the right way. Maybe they don't see the risk benefit analysis the same way that those of us on the public health side may see it. And it requires a different kind of communication. And this is where we get into the point that we are now, that we have to think about increasing access. So instead of taking people to the vaccine, bringing the vaccine to people, bringing it closer to them, and also really kind of getting in and answering the questions and thinking about not only the educational component, but also the incentives. Next slide. Oh, thanks. And so when we talk about this, willing to accept, we talk about it sort of in terms of vaccine demand and vaccine refusal. In the United States, we sort of have this really interesting mix on our day-to-day vaccine work, where we have high demand, but sometimes we sort of fall in this middle place of passive acceptance because there are policies around it, school policies, et cetera, or it's just a social norm. And those kinds of things really kind of get in there. And if you go all the way to the left of this, we have a very small portion that are in the refusal area. The challenge is when they become sort of concentrated in specific communities and in specific groups, and the reality that some of that is not geographically based, but can spread very easily on social media. Next slide. So this is really kind of the process that we go through, and a matrix that, everybody sort of takes in information different ways, but this is really looking at the matrix of how you move people from a behavioral science standpoint and from a social science standpoint. Sort of looking at all the different pieces of it in how you pull the levers of the program and pull the levers of the communication to increase confidence and ultimately get vaccination. Next slide. So that slide and this slide are fairly sort of reoriented ways of just saying, hey, we need to give people access and build relationships so that people are willing to get vaccinated and understand the vaccine. Next slide. And this is our overarching vaccinate with confidence strategy. Again, starting with building trust, but working closely with our healthcare professionals and engaging communities and individuals. And I think the first two pieces of this, at the top of the building trust and empowering healthcare personnel, I think we do a good job of this kind of overall. Where it does get a lot more challenging is this engaging communities, because when we talk about engaging communities, that really kind of asks us as public health professionals who are really spread thin to think through and work in how do you have those conversations with different individuals and different communities to meet them where they are and understand their needs and bring the vaccine to them and help them understand the risks and the benefits of the vaccine. And those motivators are different for different groups. The individuals who speak with them and work with them, the trusted messengers, if you will, are different as well. Not always the person from the government who they want to hear from. They might want to hear from a faith leader telling them, hey, this is an okay thing to do, for example, or working with faith leaders so that they don't inadvertently spread misinformation about the vaccine or about the benefits of it. Next slide. And so again, building trust and confidence in working with the disproportionately affected populations and addressing information gaps. Science takes a while to kind of filter down to different groups. And this has been really a challenge the whole time of the vaccination program, because normally what would happen is we would have that time during the licensing process. It reminded me again during the adolescent vaccination work that we are having to build this plane while we're flying it, because the thing that was taken out during the EUA process is not any of the science or safety, but is the time to communicate, the times to socialize the science with our healthcare professionals and eventually the communities who they serve and support. And so we've had to get information out at the same time that information is becoming available. And that can be really challenging as you're implementing the program. Next slide. And so I'll go through these next few slides pretty quickly, but really kind of focusing on trust. Building trust is a process. People are going to have questions. They want to have those questions. They want to have the relationships and conversation. Next slide. And again, it is more than one conversation, and it is more than one conversation with one individual or one group of people. You can't go to one event. You have to show that you're available, show that you're part of the community, and show that you're committed to their health and to support them. Because even though there are historical inequities, most people really kind of look at, what are you doing now? What are the things that you have that are happening now? How has the system hurt me or supported me recently? And those are the things that we really kind of have to work on. And then when there is a situation of something that goes wrong or a mistake that's made, sort of working with and acknowledging that and figuring out how to resolve it in the future. Next slide. And part of this process is the trusted messengers. The example I will use is that with the vaccination rollout to healthcare providers first, that provided a lot of really good opportunity for us to socialize the science early, and also for vaccination to be visible from people who are trusted in the community getting vaccinated. The joy and the pleasure and the support that our healthcare providers received and shared demonstrated their support and understanding of the vaccine that I think paid some real dividends in terms of building confidence and trust in the system. Next slide. Again, this is a two-way dialogue. So you have to listen to them, respond to them. And this is not always easy for people in public health to do, people in government to do, but it is part of that process because we cannot move forward, we cannot improve unless we acknowledge where we make mistakes and work on that effort. Next slide. So this is just kind of an overview of some of the work that we provide with our vaccine confidence team and through the vaccine task force, provide guidance, direct support, and go into a little bit more. Next slide. One of the big things that we do are these vaccine confidence consults. They're sort of a phone a friend where you can call somebody at CDC and we can set up an appointment and we'll work through with you issues that you're having where you see a lack of demand or an issue with confidence in your community, and set those up and bring experts to the table to work you through things. Next slide. And the next slide is our last one. This is our rapid community assessments. And this is, again, getting to the identifying the issues and challenges and moving to the solutions. A lot of times when people are in the middle of the work that they're doing, it can be really challenging to kind of take a step back and go through and understand what the real issues are, understand where the real challenges are, and engage the right people in the process to find the path forward. And ultimately, that's what these rapid community assessments and confidence consults do. And we've implemented several of these. We're about to do another round of them related to adolescent vaccination. And so if there are any states, any jurisdictions that want to participate in that process, you can email us and we would be happy to talk to you about that and how to implement it and how we can help you. So that's it. Thanks.
Thank you. And on to Doug, and thank you. People who are adding questions, please add your questions as you see them.
Hi, good afternoon. Thanks for the chance to speak today. It's my hope to provide perspective on how we are confronted with and tackling the COVID-19 epidemic at the level of a small Western state, Oregon, with a population of 4.2 million. Favorite quote from Cesar Chavez, I quite like this: true wealth is not measured in money or status or power. It's measured in the legacy we leave behind for those we love and those we inspire. And hopefully this is a moment we're inspiring lots of folks. Next slide. Over the next few minutes, I'll briefly review our situation as it relates to COVID, the epidemic, and vaccination. I'll then speak on our challenge to reach the Hispanic Latinx population, this group responsible for almost 40% of the cases and comprising just over 10% of our state population. I will touch on our larger response and then speak of our current out-of-the-box plans for the future. Next. This slide is our daily update for May 11th. It's notable for an increase in the daily cases through March and April and a leveling of cases in early May. The rate as well as percent positives are 3 times what they were in February. We've attributed this to increase in to the opening in schools, to in-person learning, the loosening of restrictions on businesses, and the arrival of more contagious variants. Next. This slide shows the progress we've made on vaccine coverage. As of the 11th of May, 46% of Oregonians had received 1 dose of a 2-dose series, and 34% had completed their course of immunization with Pfizer, Moderna, or Johnson & Johnson. And next. This slide shows the percent of the population by county that have been completely vaccinated. I've highlighted one of our greatest challenges, rural counties with sparse populations. As you can see, the counties in rural Eastern Oregon have a lower vaccine rate than the more densely populated counties in Western Oregon. The county highlighted, Malheur County, by our state data, has the lowest rate in Oregon. We believe things are not quite as bad there, as many of these folks actually cross the border and go into Idaho to get care, and their vaccine numbers are showing up in Idaho right now. But you can see there in the east, things are around 32, 37, 25, 31, and the west part of the state's 54, 48, 42, 57. On to the next slide. Here you can see vaccine rates by race and ethnicity. You'll notice that the Hispanic Latinx population has the lowest rate of immunization per capita in Oregon. Next slide. It's important to understand this group. It's a very diverse group, united by language and in part culture, though this varies greatly depending on the length of time folks have been in the United States. To optimize our communication strategies, it's helpful to group folks a bit. And I know this causes a huge amount of consternation, but linguistically and messaging wise, we have to group a little bit so that we can condense our how we communicate. But just briefly, the group's first generation migrant and seasonal farm workers, those born outside the US, many without documentation and often with a lower formal level of education and with Spanish as their primary language. The next group would be second generation, those born in the US or arrived while school-aged with a higher level of formal education who function equally well in English as well as Spanish. Their families are often settled and they have stationary, consistent work. Then we have the third and fourth generation, those born in the US with family connected with stable community, school, church, community organizations. Their primary language is English, but they maintain some fluency in Spanish. And the last group are those that have been settled in the US for many generations. As I pass this slide around, our office people are like, Dr. Lane, you know, there's a lot of us and our families are from there and from here, and we're in different groups. I have to apologize. I wasn't able to fit everyone in to this group, but this is to convey to folks very diverse group in terms of language and education and the type of work people are doing and how they're connected to their communities. The next slide. To better reach this population, the Oregon Health Authority put together a comprehensive plan based on active dialogue with the community, listening to the community. This includes and our plan includes a statewide communication strategy, close work with community-based organizations and local public health departments, community health centers, and especially migrant and seasonal farm worker clinics. In addition, we have since the beginning of the epidemic used radio for a weekly update of key information from the Oregon Health Authority, this in Spanish, and we always open up for questions. Next slide. This is a slide borrowed from one of our local partners who work closely with community health centers. They divided their strategy into 3 categories. This is like a beautiful overview. Number 1, reducing the hassle factor, making it easy to get in and get your shot. Number 2, earning the trust of the individual. And number 3, earning the trust of their community. It's worked well. We've seen rates go up much faster than we had actually anticipated in some of our marginalized populations. And it's continuing on all 3 of these strategies that's gonna help to get the vaccines in arms sooner rather than later. And on to the next slide. I'd like to spend a couple of minutes on lessons and some tools we used back in the height of the HIV epidemic, which kind of like displays my age here, but when there were no medications and no PrEP and HIV was a death sentence, tools that were used then, there might be some quite helpful here. And as one might remember, in the year 2000, there were close to 36 million people living with HIV, over 5 million new infections each year, and almost 22 million people had died from the disease. Most of the infections were sexually transmitted, and this is a very taboo subject in many traditional communities and societies, especially in sub-Saharan Africa, where at that time, the rate across populations was close to 10% were HIV positive, and some prenatal clinics had rates that were closer to 30%. And as mentioned, that was a time in 2000 when there were no medications, or there were very few medications. Next slide. We had to do something like now with COVID. It was a pandemic, millions were dying. And I have my favorite quote from the head of UNAIDS in the middle of this crisis. We all need to begin thinking out of the box. And I'd follow that up with a little quote from Winston Churchill, which is, not only are we thinking out of the box, but let's not waste a good crisis. Let's do something with this that's not only going to address COVID, but help us here on into the future. And next slide. This brings me to the CDC in Guyana in South America, which was the second highest HIV rate in the Caribbean in that era. Became the 15th PEPFAR country and had a budget of more than 25 million a year, just for most of 5 years. This for a country with a little more than 1 million persons. Anyone does the math there, we were pretty well funded. The country director there was kind of repetitive. He was very fond of saying, we are only limited by our imagination, our ability to organize ourselves, and our ability to get along with each other. We shared this $25 million budget with USAID, and there's always a lot of field-based rivalry between institutions. I think this is quite appropriate for today. We've got good funding. And if you're wondering, yes, that was my job, the first country director there, and this is where this kind of story comes from. Next slide. And I'll go on to talk about something that we did, I think might be quite useful here at the state level. So we needed folks then, as we do now, to believe in us, to trust us, and we needed them to be able to talk about change and about very private behaviors. The HIV communications group at CDC decided to try to use the only communication that had broad reach, and this is referring to what was done in the southern part of Africa. I'll go back to Guyana shortly. So the CDC kind of group, they also knew that lecturing traditional folks hadn't made much impact. We were doing a lot of blah, 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 and about everywhere, and there was no change in behavior and rates were going up. They decided to try to put their messaging in the context that would reach the people personally and would reach the community and would be so interesting people would talk about it among their friends and family. And they did this through the creation of a radio serial drama, or like a radio soap opera, where they worked in key communication messages and along with all the kind of stuff that happens in soap operas that appeals to all of us human beings, tragedy and conflict and that sort. Anyway, so this soap opera, behavior change through example, giving folks a story they can understand, characters that they can connect with in the context of their own culture and personal story. We scooped up this idea and created our own program for Guyana with a spread to the English-speaking Caribbean. So we not only used it in Guyana, but it went throughout the Caribbean. You can still look it up. It's still going 12 years later under the name Marundoy. It's now a larger public health messaging serial drama, not just HIV, but has broader messaging, run by a nonprofit that does 2 unique 15-minute segments each week with a back-to-back repeat on Sundays. It's a very high quality production in terms of the writing, the production, and the recording. And although it addresses many adult themes, almost more importantly, it was done so that it could be used in high schools where a lot of the riskiest behavior started. Next slide. As I mentioned, it's been on the air for 12 years now. Originally funded by the CDC, it was such a hit that within 3 years, most of the funding was no longer US government. It was actually, or PEPFAR, it was covered under the community. And why don't you go to the next slide there. Here's a list of our sponsors they have today, which of course you can imagine leaves me with a huge smile that we started something more than a decade ago that found its own feet and its inertia, and it's still there making change, and now in the middle of the COVID response. Last slide. So to wrap up, it's our hope 6 months from now, a year from now, 2 years from now, we'll all look back and believe that we've learned something, and that even as a state agency, we're better at understanding our capacity and our role and our responsibility. We're better at understanding those who we're here to serve, that we earn and engender the trust of the public, that we put tools and structures in place with long-lasting benefits, and that this kind of complicated thing of like what happens on what level, the responsibility, the funding, responsibility, and programs, federal, state, county, and municipality, that we get this right so we're optimally effective. And that's my presentation. Thanks.
Thank you. And again, add your questions to the Q&A and we'll get to them following Jens. And I'm very eager to hear his presentation.
Hello, everyone. My name is Jens Dakin. I am the Managing Director for Strategic Engagement, which is also encompasses information operations and strategic communications at AM LLC. And if we can go to the next slide, please. So we have 2 companies. There's AM and AM Trace. AM is about 10 years old. Sorry, this is what I'm going to talk about in the presentation. So describe who we are, and then provide some ideas about our approach to target audience analysis that informs the communications process. Our approach, which is a behavioral approach to engagement, and then offer at the end some ideas about planning and introducing a planning framework that we use, something that we've developed over the last few years. Next slide, please. So yeah, back to who we are. So AM and AM Trace. We're the same company. AM was formed about 10 years ago as a federal contracting company delivering research and stratcoms and healthcare IT solutions to the federal government. And then about a year ago, in fact, it is a year ago this week, AM Trace was founded to directly provide support to COVID-19 response operations. And then you'll see on the right-hand side of the slide, these are all the services that we've built up over the last year. We started with case investigation and contact tracing. And out of that, developed all those other services. And if you go to the next slide, let's just highlight at the bottom, you'll see what I'm primarily focused on, which is the strategic communications and community engagement. Where do we work? So you'll see a list of the countries where we are currently working, sorry, the states where we're currently working. And we're providing, community engagement services, policy and strategy support, help desk support, where we're contacting people and informing them about vaccinations, and also as part of the contact tracing process. And for example, in New York, we have engaged with over 350,000 people. We've booked 50,000 vaccination appointments, knocked on 165,000 doors, and had an additional 180,000 conversations with people in the 5 boroughs of New York. So it's very busy. We've got huge teams in California and New York, and we're setting up teams in Vermont as we speak. Next slide, please. So to provide a bit of context about vaccine hesitancy and lack of confidence in vaccines, I don't want to go into too much detail because it's preaching to the choir here. Everyone is working with this issue day in, day out. So we know the context, but it's very widely known that hesitancy isn't just specific to one particular demographic. It is very common across every race, gender, religion, political belief, etc. And it affects people in rural and urban communities. And what we're seeing, a lot of the research that's being published and we're reading, is that there are some very stubborn groups within society who, more so for ideological purposes and potentially political belief purposes, are extremely hesitant to get the vaccine. And so from our perspective, as communicators, we focus a lot of effort on target audience analysis and identifying the drivers behind an individual or a community's vaccine hesitancy, and then try and understand what barriers they have to vaccine acceptance. So we invest a huge amount of effort understanding the target audience. Next slide, please. So this is there's a series of slides coming up that just show very briefly that vaccine hesitancy exists on a broad spectrum. And on the left, you have those who are already vaccinated, and to the right, who are, for various reasons, are adamant that they will not be vaccinated whatsoever. And at the bottom of the slide, just showing, what the policy objective that we're supporting is, firstly, to get people the first dose, and then turning those first doses into second doses where applicable, and thinking into the future. There's been talk of potential booster doses this winter or this fall, and that it may become an annual requirement. So this is something that, as a communicator, we have to prepare for. Next slide. So on the left-hand edge of the spectrum, this is where the mass marketing campaigns have succeeded, okay? And you have people in those demographics who are highly persuadable or already persuaded. So they've succeeded. But where the mass marketing campaigns tend to have less impact is on the right-hand side of the spectrum. So next slide, please. Okay, so we're a bit busier now. But this is where we want to focus on. This is where we are focusing on right now, is those target audiences for those target audiences who've expressed an opinion that they're waiting and seeing for whatever reason. They're concerns that the vaccine was developed too quickly, or they're just nervous about other side effects. And then you have people who have said that they probably won't take the vaccine or probably won't accept the vaccine. But that doesn't necessarily mean that they're not open to persuasion. So in those groups, you have people who are highly persuadable and possibly persuadable. So what we strive to do is better understand exactly the barriers to change, barriers to acceptance within those target audiences. Again, try and reach those audiences that the mass marketing, ad campaigns haven't had any impact on whatsoever. Next slide, please. So we developed over the last few years, and my personal background is national security, public diplomacy, international development. I've also worked on energy and healthcare a bit until last year. So over the years, we developed at AM a 7-step process that focuses on and takes a behavioral science approach, but it is we have developed it and tailored it to COVID-19 response, but it is applicable across a number of healthcare scenarios. So we've developed something that can be used for healthcare providers. So next step, please, in the slide. So this process, key to us is understanding the target audience. So we have a number of inputs into that process. Next step, please. So here you'll see, all the, some examples of the information we need to form our target audience analysis. So it's quite an in-depth and detailed process that we go through. And once we've collected all that information, it gets fed back into our planning process. So the next step, please. So the target audience analysis framework, a lot of information, and it's conducted for each specific target audience, whether it's white males between 18 and 29 in a particular location, rural or urban. We do one of these studies for every target audience that we want to reach and engage with. So that gets fed into the process and forms part of the cycle. The next step, please. And this provides an example of the questionnaire that we like to use. We have about 100 questions that we can customize depending on each scenario, where we really drill down into the environment and the context in which that target audience exists and lives. So we can, really, pick it apart and find opportunities for messaging and to knock down these barriers to change that they may have. Next slide, please. Okay, so all the information that we have gets processed into a campaign plan, a planning tool. And this is another template that we have developed, which helps communication planners and policymakers provide an overview of all the information that has been garnered from the target audience analysis process. It gets summarized into here that can be used either for a briefing purpose or as a planning guide to develop a much more comprehensive strategic communications and engagement plan. And it highlights, at the top, you see the policy objective and then a strategic narrative, provides details on target audiences and then, communication goals and behavioral goals. And then also highlights local and cultural factors that affect that target audience. And this aligns directly with the planning process. So if you go to the next slide, please. It's continued on, we have developed over 2 pages where it provides guidance on tactics and techniques to consider, outlets, media outlets and products that can be used, and also provides messages and also a sort of an overview, a very brief timeline and a synchronization matrix of the campaign. And this is very draft. It is customizable. We do use it and I use it. I'm using it this morning for a location out west where we were asked to look at, or where we have been asked to look at, a rural population that is very hard to reach. And so I'm developing message strategies based on our target audience analysis. I'm having to think creatively because they haven't been affected by engagement or community engagement campaigns or mass marketing campaigns. So we're having to think out of the box. So that's something I've been working through this morning for a customer out west. And I'd be happy to discuss some of those ideas with people offline or in this forum now. But I've come to the end of my time, so that's all. And here are a few things to consider when conducting your plan. So
Wonderful.
Thank you.
Great. Let's open up for questions and answers. And thank you, Jens. And yes, the slides and the tool will be available online, and we'll get you those links for all of you who've been asking. Let me turn. Obviously, states don't have a lot of time and great urgency to move this issue. Lots of questions about the new requirement, the new opportunity for children. What data do we have that tells us about parental hesitancy? What do we know about parental hesitancy and how to reach parents? And are there any tools out there that can help do so? Jens, anybody? I'll open these questions to whoever wants to jump in.
I mean, I can start. We've been looking at this and asking this question even before the manufacturer submitted the amendment to their authorization. Overall, the sort of anecdotal information and sort of the initial work that information that we've been hearing through our surveys and information from states has been, it's similar, but maybe a little bit more hesitant. And I think the idea of, for those parents who are high information seeking and maybe a little more reluctant, the issue sort of comes down to the perception, to a couple of things. Sort of the perception of newness of the vaccine has not been given to very many children, and then the potential long-term effects of the vaccine. And this, requires a lot of work to kind of really think through it. But we've had new vaccines for children, new adjuvanted vaccines, and with varying degrees of success in launching them initially and building them out over time. And so, it's not insurmountable, but I think it does require an environment where those parents and the children are comfortable having that conversation with a trusted healthcare professional, which is why a lot of our effort is really focusing on educating parents and using the various trusted messengers to reach those parents. And two groups that we've identified very early on, pediatricians, family physicians, of course, healthcare professionals, and then faith leaders. I think there's some real opportunity there to educate faith leaders so that they are able to address issues and concerns that come from a community faith perspective, but also direct and redirect to healthcare professionals who can give more concrete answers and also to prevent them from inadvertently sharing misinformation.
And Richard, are there any surveys yet about parental hesitancy or any actual talking points that states can use?
Yeah, I mean, this kind of gets to the issue of, people have questions. Again, this is new. And so right now it's the how do we answer the questions piece of it, going back to the science and making sure that the people answering the questions and having the conversations are people who they trust. There's so much foundationally that gets to this. You saw Jen's very complex effort and work in taking all of the behavioral science efforts to get to this. And there's a lot that, so there is no sort of magic bullet or silver bullet to kind of answer or fix all of these things. It really is understanding where individuals are coming from, and getting them the information that they need to be able to make the decision. So it is very much a conversation, and there is a lot more listening than there is talking.
Can we talk a little bit, and I'll ask anybody to jump in, sort of the notion of incentives, and there's lots of creative stuff out there from cars to money, versus mandates, and what are the legal and policy implications that the public needs to know about mandates? It seems like, we see especially university systems mandating. Tell us about mandates versus incentives, and I'd ask each of you to weigh in, whoever wants to jump in first.
Yeah, this is Doug jumping in. I hope we can be a little bit patient. I know we all want this to be over and we want it to be beyond politics, but I think that will come. I think we need to be consistent, and as noted, having folks reach out to their trusted healthcare provider, to their faith community, and I hope within a year it'll become like the flu shot or like tetanus, and we'll look back on all this and think, wow, we had a lot of worry, but it wasn't so much to be worried about. That's what I hope. In terms of what do you do in the healthcare setting when people are around other folks at risk? I know in Oregon, we worked out historically, if people didn't want to get their flu vaccine and they worked on the front line in the healthcare setting, that was fine, but they had to wear a mask. So I imagine we don't have any specific policies requirements now coming out at the state level, but I suspect we'll look at doing something based somewhere on what CDC recommends, and then what historically we've worked out with unions and all in terms of the flu shot.
And what about the legal issues? Because of the approval process for this vaccine, there's questions about whether it can be mandated. Where are people on the mandate issue? What are the
I think till it's fully approved, I don't think anyone is going to be able to successfully, push a mandate.
A lot of people are doing it in schools, particularly colleges.
Yeah. My background is not law.
Yeah. Anybody else on the mandate versus incentive question?
So I'll frame it's not a versus. There's a continuum of creating demand. And we are at the point of thinking about access and incentives. How do we make this positive and sort of shift the risk reward of people's perception of, do I go wait in line? Do I go to the doctor's office? Do I, all of the things, the barriers that Doug laid out in his Venn diagram. So all of those things, it is a continuum, and at some point, in order to really kind of get to everything, there are policy levers that will likely have to be considered, and that is a different conversation, and I think to your point, Trish, to your point, Doug, that this is. We're at a point where it's an emergency use authorization, so the law is a little fuzzier, as opposed to a licensed vaccine and a vaccine that is recommended on the CDC vaccination schedule. And so those two pieces, as we kind of build that out over time, that's those kinds of questions I think will be, people will have the opportunity to discuss them and address them more directly. But just in general, the laws around mandates, and I think most people on this call probably know that, are state and local based, and also employer based. So that's where the discussion will really kind of turn.
Anybody else? Okay, let's talk. We've talked a little bit about kids and the issues of getting to parents. What about the sort of challenge of the ideological challenges, the challenges of rural, more conservative areas? What messages and strategies resonate with that group? I'm thinking of your early chart, Richard, where you show there's a group that just say no. There's a group that are, can we get to the just say no group? Can we move them? And especially those who are ideologically bound, more conservative. What strategies work? Anybody?
Yeah, hi, this is Jens. This is the demographic that we're being asked to look at more and more because they're the most stubborn and the most resistant to change. And it's a challenge because, you know, you have to look at their sources of information, why this audience thinks the way they do, and then come up with a strategy to either intervene, you know, to drive a wedge between their sources of information and try and provide them with an alternative source of information, which is very challenging because, you know, what tends to happen is if people think they're being you know, influenced in any way for whatever reason, they will put up the shutters and become even more defensive and entrenched. So you have to be very, very patient in doing that. And that's just one option. There's another, you know, some other strategies that you can employ that, you know, are potentially more aggressive and more proactive from a communication standpoint, and may not be you know, acceptable by you know, a local health authority or a government, but it's, you know, it could be calling out the source of that information, whether it's misinformation or disinformation, and being aggressive, being a bit more aggressive in terms of calling it out, and you know, then presenting an argument to the target audience. That may or may not work. It depends on the analysis that you generate from your target audience analysis. Everyone has their triggers. Yeah. Other things we've been looking at is, you know, if people, you know, from a social norms approach, you know, what happens if they're being held back by a perception in their community, you know, whether it's in their church or their, you know, their softball league or whatever. So giving people an opportunity to get a vaccine, you know, surreptitiously or outside the county or wherever, you know, giving them an out, you know, a respectable way of getting a vaccine where no one will know. So you've got to be creative. So, you know, it's the whole spectrum of what works and what doesn't work, but some are acceptable, some are more aggressive, some are more palatable. But.
And have you seen some specific examples that you could give us of things that have seemed to have worked?
Not yet. No. Watch this space.
Okay. Okay.
So, one thing I'll talk about, and this is not so much a direct in the communication standpoint, but it really gets to the fact that we may not be the right people to share that message. We you know, finding and identifying who those right people are. Interestingly, there are several states that I've spoken with who are working with their Department of Agriculture and really kind of putting it in the perspective in working with a partner government agency who they're going to listen to more likely than a public health entity or a health professional directly, to talk about the benefits and share the value of the vaccine and how that can have a really positive impact on their life and their work and getting back to normal. That's been effective because, again, it's the right messenger for that audience.
We've got a specific question here. What messages and strategies would you recommend and where to disseminate them to quickly implement to address the concerns about, do you have to pay for the vaccine? Do I have to provide my social security number? Just the basic things people are worried about. What works there? What's the message? Anybody?
So this is Jens. It's a very difficult to provide a specific answer to a sort of fairly generic question without understanding who the exact target audience is and where they're located, what their media habits may be, because, you know, for some people it is very much, you know, a face-to-face conversation from a community engagement team or a trusted voice, or it could be an Instagram influencer. So there's a broad spectrum of how and where people get their trusted news and information from. So, you know, that's part of our process, is that, you know, we really drill down into, you know, where people get their trusted source of information from.
And if the trusted source is critical, then what do you do? If the trusted source is a skeptic,
then you try and introduce another source that you've got to be creative and say, okay, this person tells you one thing, but also, you know, because we know their media habits, you know, maybe there's someone on the fringes that you could bring into the center of the conversation that does have, you know, views that are more in line with what you're trying to communicate. So it's a step-by-step process.
And as Doug jumping in, I think we do have to be a little patient. If one were to look at the country that had the most vaccine the earliest and the uptake, and now it's kind of leveled off, that's Israel. I don't know if we have that little graph available there. Pull up on PowerPoint. I think we'll notice that in Israel, they had close to 60% coverage at the early April, and the uptake much above that has been kind of slow, but gradual and persistent. And it is going to take some time. The political atmosphere of this whole thing arrived in, and I think there we go, where we can see it was actually a little bit earlier in March. They got up over 60% of the population, and it's been a slow, steady decline. If you look at the United States, we're still on pretty much the same upward slope. It's more related to vaccine availability than confidence or hesitancy. But I imagine we'll arrive at a curve much like the one that we see there for Israel. Hopefully, it'll be a little bit higher.
and what did Israel do? What lessons can we learn from Israel to get that trajectory?
You know, it's been followed quite closely by the New York Times. So if anyone has a subscription and they Google the New York Times, they'll find half a dozen articles that followed Israel through this process. Early on, there was quite a bit of resistance from very conservative Jewish, Orthodox Jewish communities to vaccine. And there were groups that were putting posters up all over different little communities, anti-vax posters against COVID. And they described in this very good article how they just got people together, they took down the posters and put up their own posters, and they were better looking posters that had a positive message, not a fearful message. So it was even just something as simple as that, getting rid of the graffiti.
We're running out of time. Let me ask one quick question. We've seen some very creative strategies by states. In Alabama, you might be able to ride in a pace car. In Tennessee, you might be able to win a car. In Ohio, you might win $1 million. In Maine, you get LL Bean certificates. Will these strategies work? Are they adequately targeted? What do you think? Could they backfire?
I think they will work for some. You know, they will work for some people, but they won't work for others. Yeah. And it's just, you know, the challenge is how do you reach the others, the reluctant holdouts.
So, anybody else?
Maybe it's my age, but I look more and more at longer term kind of sustainable solutions and relationships. And I would really like our Oregon population to trust and believe in us more when this is all done, and doing kind of one-off fancy high profile things that so annoys me. Maybe it's going to have some effect, but I would rather do the hard day-to-day work, you know, get people in to see their primary care doctors, give their primary care doctors the right information to pass to people, make getting vaccines easy, get out there and talk with communities that are reluctant. Don't just sit in our offices, you know, our homes working virtually, but really make an effort to use that shoe leather that they talk about in epidemiology.
Richard, any last words for the states that need to act immediately?
Yeah, no, I mean, so all of these things are opportunities to open the conversation and build a relationship. I think that's the thing that we're hearing from a lot of health departments and a lot of people on the ground is we've always had a hard time reaching this group or this population. How do we start? How do we open the conversation? Who do we talk to? What do we say? And anything that can help get you to that point of starting that conversation and building that relationship will pay some immediate and many more long-term dividends from the point of view of public health, I think, to Doug's point.
Okay. With that, it's the hard work of public health and states to get into the communities to understand the differences, their expectations, how they get information before you can solve this problem. So we very much appreciate this panel. Thanks again to AM Trace for helping us.